of you are well aware, we operate on tight margins, and every area of margin that we have in our hospital, we want to purchase tools for our clinicians, for physician, nursing, all through the hospital, whether it's putting in new carpet, new computers. And when you get hit with the ransomware attack, the impact is real. We're going to kind of walk through that. Again, I'm not sure, again, in the audience, if there's anybody here who doesn't know where Sky Lakes Medical Center is located. We're in South Central Oregon, and we're a sole provider in the area of Oregon that we cover. So we're essentially between Medford and the eastern area of Lakeview. And if you want healthcare in our area, you have to drive to get there. So you have to go about 140 miles north up to St. Charles, about 100 miles east out to Lake District Hospital, or 100 miles south to get to Modoc Medical Center, or 72 miles over the Cascade Mountain Range to get to Asante Health System. So we have about a 75-mile radius that we take care of patients. It represents about 100,000 patients in our area. On October 26th, we experienced what's known as Ryuk ransomware. So just imagine with me, you're at home sleeping away at 3:30 in the morning, and you get a phone call, and one of your staff says, "We've been hit with ransomware." And I've been in healthcare IT for about 20 years. And I was told by a former CIO when I was at UC San Diego, it's not a matter of if, but when. And I'm a competitive person by nature. And I'm going, well, let's just build our strong defenses and do everything we can to protect ourselves from ransomware and cyber crime. Well, at 3:30 a.m. on the 27th, I received my phone call. The phone call came in because at 1:30 that morning, so 2 hours prior on Tuesday, October 26th, Information Services received a phone call stating that the systems were slow, the computers are slow. So that was the first symptom that was presented to us, was slow systems. So what happened? I'm going to kind of walk you through that now. At 12:08 Pacific time, so 8 minutes after noon on Monday, October 26th, an email came in to one of our employees at Sky Lakes Medical Center. And that email stated, if you'll click here, you'll receive a bonus. I'll show you what that email looks like in just a minute. But just to give you some context for a timeline for how quickly this all happened, at 12:08, the email was clicked on. Within about 30 minutes, the system went to what's called the 0-day site. That means the bad actors, the bad guys, set up a malicious site out in the cyber realm where it would go up, receive a payload, pull it back onto that computer. The person who clicked this, her experience was her computer she got this bonus email. And by the way, she had just met with HR earlier in that day and was having conversations with HR. It didn't happen to be about bonuses, but she had met with HR. And when we start to talk about these things, we start to talk about kind of the psychology behind what the bad actors are doing, or how they try to get us to click on these phishing emails and these links. But she clicked on it, and her experience was that her computer froze up and she couldn't control her mouse. And she thought, wow, that's kind of strange. Once she was able to regain access to her mouse, she went ahead and closed that window and didn't think much more about that. Well, about an hour later, the first code is called the PowerShell command called co-op strike was enacted. And at 10:50 p.m. on Monday evening is when the ransomware binary executable was actually executed, and files at Sky Lakes Medical Center started to be encrypted. So now you can kind of go back to that 3:30 in the morning call the next day. So at almost 11 p.m., our systems are starting to encrypt files. Our systems are starting to take all the CPU usage on the computers, and the files are beginning to be locked by this ransomware. Here's the rendition of that email that came in. It was for an annual bonus report. Each one of these underlined links were hyperlinks. I'll show you what those look like here in just a minute. But each one of these, if you would click on any of them, would go to the bad malicious site. And let me show you what that looks like. So here are the actual links from that email that came in, and they're just standard Google documents. So if any of you use Google Documents, this is exactly, if you send somebody a link for a file, this is what it used, a standard Google link, and it doesn't say anything in there, you know, Ryuk or Russia or Stan nations or anything like that. So there'd be nothing there that would tip you off. When our team received the call at 1:30 a.m., when they finally found out that it was ransomware, here's what they saw. Here's an example. I know this is a little bit blurry, but this is just to show you what it might look like on a computer. You'll see these .ryk. All those file extensions end in .ryk. And so that's what happens when the files on the computer get locked. They're renamed and they're all Ryuk, and the only way that you'd be able to access those files would be to pay a ransom. You'd receive a key and it would unlock it. And by the way, that hasn't always been successful. So there's part of the challenge in paying a ransom, but this is what the files look like. They all lock, and you no longer have any access to any of the files on that system. Interestingly, the FBI, Department of Homeland Security, and Health and Human Services had a webinar and had a meeting, and maybe some of you attended it, on October 30th. So just 3 days after our attack, they had a webinar because they were receiving intelligence that healthcare was under threat. And the threat was, they were saying there were about 400 hospitals that could potentially be attacked on this day. And it just so happened that Sky Lakes and 2 other hospitals we were at the tip of the spear. It was the University of Vermont Health Network, St. Lawrence Health System in New York, and then Sky Lakes Medical Center here in Oregon. So all 3 of our hospitals literally were attacked very close. I know the St. Lawrence Health System, had an opportunity to speak to them and their team. Somebody at their hospital clicked on the same email at about exactly the same time. It was 3 p.m. Eastern time on the 26th, and at Sky Lakes it was 12:08 Pacific time. And so this webinar just came days after we were hit with the ransomware. So I'm going to kind of now walk you through what it was like after that. So we've been hit with this ransomware, and I want to really have you understand, for us, it was a perfect storm. And so the other piece that's so important for all of you to remember, and I know you probably remember it well, is this was right at the slope when that curve goes up for COVID-19. So our nurses and physicians and incredible healthcare team, as they're ramping up to take care of a hospital with COVID, and we hit our maximum numbers during this downtime. So you have to add that to that. So the stress and strain of trying to take care of your community and take care of patients around COVID, and especially as we were learning so much about this disease, we were hit with the ransomware. And so there are 3 things I want to call your attention to that made for us for a perfect storm. The first was we were already having some issues on our infrastructure, and we had a ticket in with the vendor, and it was causing slowness on the system. So that added some of the delay to the diagnosis to understand what was going on. Secondly, we were right in the middle of implementing a new system at our hospital to protect our computers and servers, and that's called it's Cisco AMP for endpoints. And thirdly, where we had it deployed in the configuration, that configuration process was not complete. So when that link was clicked on and the executable started on our network, it started to move across the network and infect our system across our network. So one of the early challenges that we faced was our cyber insurance. Who could we use? We realized this was much bigger than us just trying to take care of this. In fact, initially, we started to restore systems. And early that morning, about 5 a.m., we understand how important communication is. For example, for nursing, Sky Lakes, we use an application called Vocera. It does hands-free communication for us. We were trying to get that back online for nursing to be able to have that system. And as soon as we brought it online, it was wiped out. It was encrypted again, so it couldn't be used. So while that's going on, we're trying to work with cyber insurance to find out who can we get to get some expertise to help us walk through this. Make a long story short, it took us about 2 days working with insurance. Insurance gave us a company called Kivu Consulting, and we ended up having Kivu Consulting really help us focus on the recovery effort. And then we had Cisco provided Cisco Talos, an incredible company that helped determine root cause. What we knew is we needed to know the who, what, why, where, when, and how. So Cisco came in with their forensics teams and their experts to help us determine that, and then to also help us fine tune these products that I was mentioning earlier that we were in process on, get those fully configured. So let me kind of walk you through the ABCs of the steps that we took. So the first thing we had to do was shut all systems offline, turn everything off. We didn't know how far, wide, and deep the encryption was going through our systems. So we use a product called Cisco Teams. Maybe many of you use that. So another one of our initial challenges was communication. When we say we had to turn all systems off, we mean everything. The electronic medical record, email, all systems, cardiac monitoring, all systems go offline. Now the monitors themselves, the cardiac monitors themselves locally would be on and powered up, but disconnected from the network. So no information is going to flow from your monitor back to your EMR. So that meant Pyxis, your med dispensing systems, all offline, unplugged from the network, powered off and unplugged from the network. So that was the first step. And then it was also powering off every computer in the hospital, because we had to decrease the movement of this and the destruction of this across the organization. Secondly, we're what's called the Community Connect. Maybe some of you today are you're using Epic as your EMR, and you have a Community Connect, or you're aware of what it is. But for those of you who don't know, Asante Health System runs Big Epic for us, and we sit on their system and use their database to run our electronic medical record. So we had to contact Asante, and we had to ask them to cut off the pipe. And on the right side of your screen, you see a text that I had with the CIO, Dr. Lee Milligan, who's an emergency room physician by background at Asante. And I called them that morning. It was 7:27 a.m. when I called them and said, Dr. Milligan, we've been hit with ransomware. We need you to disconnect our systems, totally disconnect our systems. So that's exactly what Asante did. And interestingly, in my exchange with him early on in this is at 7:48 a.m., I was reminding him that this was Ryuk ransomware. And I had asked him, do you have any recommendations for third-party firms that could help us through this? And one of them that he mentioned was FireEye. And just a matter of months after this event, FireEye was actually hacked by the bad guys as well, just to show you how prevalent this is and how much more prevalent this is becoming in healthcare. And it's very, very problematic. So the third thing we did, the C, is we first of all established a command center. So information services, we moved up to the second floor of our hospital, the older part of the hospital, the non-clinical area of the hospital. And there was a very large room up there called the General Education Conference Room. And we brought our teams together there, and we established communication. So now remember, all of our systems down. Fortunately, because earlier in the year, in February, you guys all remember January, February, a year ago of 20, when COVID started, we had to go start doing virtual work, right? And virtual meetings. So we had stood up Cisco's WebEx Teams. So we had that in place. And just know that that was the only means of communication that we had. The other means would be our cell phones with, texting, right? So those are the two means of communication. Everything else is down. So we had huddles. Initially, we had huddles, not at just 8:15 and 5 p.m., but we had them every couple hours that day. So at 8:14 a.m., again, just to remind you of the scale. So at 12:08 on Monday, this was clicked. At about 11 p.m., we started the encryption. At 1:30 a.m., we were notified of system slowness. At 3:30 a.m., I was notified. At about 8 a.m. that morning, we had sent a Teams message out. We need you guys to shut down every system in the hospital. If you're near a computer, please turn it off. This is ransomware that we've been hit with. So we started that 8:15 huddle on that Tuesday morning with conversation, knowing very little of the extent of this, how long is this going to be, but that's how we communicated. So we'd come back together and do virtual huddles through Cisco WebEx Teams. And again, that was our communication thread. And because we didn't have email up at the time, we couldn't add the entire hospital to that communication. So now it became word of mouth. It became director to managers, managers to supervisors, supervisors to staff, et cetera, throughout the organization. Another challenge and was just prioritization of what do we bring up and what order do systems come up. Of course, our focus was laser focused on our clinical systems. And that first clinical system that we're focused on was bringing up our cancer treatment system. As you guys all know, cancer doesn't wait. It doesn't go on a vacation while we're not able to provide radiation or medical oncology treatment for our patients, but it was prioritizing systems. Let's give you an example of the challenge this is. So this was end of October, coming in November, we were going to have our first snowstorm. And all of a sudden, facilities came to me and said, John, we don't have access to our systems and we can't start up our heating equipment to get stuff heated. Our sidewalks, all of those systems are now controlled by computers. We need to get those systems going. So this process of prioritizing systems and how they came online was really fluid. And again, focused on clinical systems, but we'd have these other systems that would need to come online as well because of circumstances like that. Let me kind of walk you through some of the details of what we had to do on the IT side to bring this online, and we'll talk about some of the clinical processes. So we had to restore and rebuild every server. So we have about just over 600 servers at Sky Lakes Medical Center. We had to bring them online. We had to install this software on them to make sure that they were clean. We had to make sure that when we brought these servers back online, that we didn't reinfect the clean areas, or we'd have to start this process all over again. We were told by Kivu Consulting, we want you guys to know this is not a marathon. And as I learned, or a sprint, this is a marathon. And as I talked to a consultant at Gartner, he said, no, John, it's not just a marathon, it's a marathon of marathons. And he was exactly right, because we're here now in March and we're just coming off of restoring all of these systems that were offline. On the computer side, the same thing. We had to redeploy. We had about 2,500 PCs at the medical center. About 680 of those were Windows 7 computers. So we had to replace all of those Windows 7 computers or re-image every PC in the hospital. And so again, we were down, ended up being down in Epic 23 days. So this is having none of these systems available to our clinicians. So those of you who work in clinical areas, you can start thinking of all the work. It's one thing to be prepared for 24 or 48-hour downtime. It's a very different conversation when you start talking about 5, 6, 7, 10, 23 days of downtime. We had to also do this process of reevaluation, not just on servers and computers, but also all of our third-party systems like Pyxis, your diagnostic imaging, ultrasound, MR, X-ray, your smart pumps, your cardiology equipment. All of this we had to do assessments before we could bring them back online to make sure they weren't compromised. And then for every person in the system, we had to have everyone change their passwords. Every password that we had was compromised. So we had to go to every employee in the hospital and change passwords. And so we adopted what Asante Health System had, was a minimum of 13 character passwords, not only for all of the employees of the hospital, but we had to also do that for all of the vendors that we use in the hospital. So that was a huge focus just in the password change. So the first system to actually come online was on November 7th. Again, we went down on October 26th, November 7th. We were able to bring the system online, but it took another 2 days before we could release that system to the Cancer Treatment Center, because we had to validate those systems, make sure that they were working. We had to make sure we had to contact the vendor. And here's a couple examples of that. We had to contact the vendor and show them and prove to them that it's safe for them to reconnect. They had to change their passwords, and that the environment they were connecting to and the environment that their system was running in was clean. And so we had attestation forms that we sent out to the vendor. And then for us, all of our energy was focused and honed in on bringing up Epic. Our team would not stop until we could have Epic back online, because I had the opportunity yesterday to interview our now acting CNO, Ron Wojda, and Christy Wiles over ICU in the med-surg areas. And Christy relayed to me that the stress of the downtime was actually more so than even COVID. So for those of you who are a clinician and know the stress around staffing and the unknowns around COVID, they said that this was even more challenging. Again, we have great processes for 1 day or 2 days of downtime, but when you add all this time on, it becomes much more of a challenge. So in order for us to reconnect to Asante had never experienced anything like this. We had to actually create a memorandum of understanding. And so there were a number of days of back and forth and conversation on here's what it's going to take for you to reconnect to our EMR. So in this MOU, there were 4 pillars. There was a whole bunch of other details under these, but we had to have a clean bill of health. We had to document that we're going to share our risk assessments and pen tests and summaries of those. We had to have very timely notification going forward, because again, the actual encryption happened at 11 p.m. Asante was notified about 7:30 a.m. the next morning. And then we had to agree on a security framework that we're going to run our systems on. We had to also provide a go live plan. So if you're off on paper for 23 days, when you come back on your EMR, it's like another whole go live. And I'm sure many of you have experienced go live on EMRs and understand the work that goes around that. This was just some of the whiteboarding in the moment that we did to come up with our go live plan. And what are all the systems that we need to turn on for Epic to go live? It's not just the EMR, but it's all the nursing systems. So for us, space labs, the cardiac equipment, for diagnostic imaging, the PACS system, for pharmacy, Pyxis, for lab, your data innovations, which is the integration engine that helps the instruments talk to the EMR. And there are a number of systems there. And then also all the servers around it, like our interface engine that passes all your orders and results through your systems. All of those systems had to simultaneously be cleaned up, come back online, and restored from clean backups. This is an example of the other challenge we had. Was our PAC system was a legacy PAC system that was completely encrypted and could not come back online. So we actually, in that time frame, stood up a brand new PACS, because again, if you needed an X-ray, you'd have to drive quite some distance. If Sky Lakes did not provide that as a sole provider for our community, if we didn't provide those MRs, CTs, and those services to our community, hitting wintertime, again, having to travel, the challenge of that. So we actually stood up a brand new PAC system during that time as well. This is just a picture of the wonderful nurses and physicians and the team that came together to do. We had to take 23 days of back data for any inpatient in the hospital, get all of that data back into the electronic medical record before we could bring Epic back online. So in the end, again, 100% downtime, full paper, 23 days. We went live on Epic on Wednesday, November 18th at 10:30 p.m. Email was not restored to the organization. And between day 30 and 40, somewhere we had a email restored, and it was restored in a limited fashion. And then nobody had access to their personal drives. Think of your policies, documents, personal documents. We didn't have access to those things. But now you have to multiply this times across the system. Health information management, finance, clinical areas, operations. So there were a number of days that the team didn't have access to Chronos to look at your schedules, to see who's on the next shift. We didn't have a way for everyone to communicate. So it was using cell phone and texting to do that. It was interesting during that downtime. where this story becomes so powerful. In one of our stand-up huddles, Christy, again, one of our incredible directors at Sky Lake, she goes, John, I just have to tell you the amount of work we're doing just to keep up with patients' medications on a day-to-day basis, the time it's taking nurses to write all this out on hand. So what we did is, after hearing that story and the impact and the concern that she had for patient care and quality of care and all of those kind of things, got some of our nurse informaticists together and said, what can we do to innovate? Well, they ended up creating, we took some of our backup computers that we had throughout the organization that were disconnected from the network, and the team built out some Excel spreadsheets. So all of a sudden, instead of handwriting labels, we could create labels, we could print those out on a local printer, and we could start automating some of those those downtime processes. So this is an example of the team. They went in and put this together so that nursing could save time and just that stress, because as Christy related to me, in the downtime for a nurse, it's one thing to do it in an electronic medical record where you have your history, you have your past medical history, you have your allergies, you have all this available, but now you don't have that available to you. And what are you missing? The stress of that, and focused on saying we want to take good care of our patients. And so coming up with processes like this were huge in the middle of our journey. So some of those clinical impacts that we were faced with, I remember a nurse coming up to me and saying in the ED, and he goes, John, I just want to tell you what my world's like trying to do patient care with none of our systems and giving a medication. I don't have the 5 rights, administration, the right patient, the right dose, etc. I don't have that full access to that record like I would normally have with the EMR. So we make these investments in technology for a reason. And that past medical history, one of our physicians, Dr. Niskanen, would talk about how if a patient came in and couldn't communicate well, or we couldn't get a patient history from that patient, just trying to find a phone number to call a family member so we can get any information about this patient history. In my interview with Ron Woida, Ron said, John, we've worked out our downtime. We've worked our downtime out of our processes, meaning before, when this was all on paper, we had additional people and FTEs like unit secretaries to move labs, right? To help us move through these processes. And now we've become so efficient with these things, we don't have those resources anymore. So just getting a patient history was a challenge. And then how do you place an order? We have a whole generation of physicians and nurses and respiratory therapists that have come through, and all their training has been electronic. It's all been online. And so how do you do that? The EMR prompts me through that process. Now I got a piece of paper and I'm trying to write an order. Those were real things. And Christy relayed to me that she said, we really had to rely on those nurses that have been here a long time, that did it on paper, because we were having to recreate those paper processes and efficiencies in order to take care of our patients. Ron gave me a great example. Guess what? We no longer had bins down in the ED to move tubes of blood up to the lab. So very, very practical things that we learned through this. Again, a lot of this you can get around with an 8-hour or 24-hour downtime, but when you start going days on days, it's a very different story. And then the communication, the second big challenge was just communication. Fortunately, we still had whiteboards in our patient areas where we could communicate with whiteboards, huge for patient continuity of care. And then the challenge of communication between lab and pharmacy and imaging and nursing and tracking specimen orders, and physicians writing orders, multi-day orders. That works really great on an EMR, but on paper, when you future those orders, that doesn't work. So we had to, again, change those processes in the moment so that we wouldn't miss orders. And I mentioned it earlier, just for staffing and contacting staff, had to rely on our cell phones for that communication. There's also not only the clinical impact, but also the financial impacts. So can your organization weather 2 months of not sending out a bill, having no revenue coming in around billing? So for us, our first patient bills came back not until December 28th. So from October 26th to December 28th, Sky Lakes Medical Center did not send out a bill. On the inpatient side, we didn't get a bill out for the inpatient care that we gave until January of this year. So from October 26th to January. So that delay, huge delay in revenue. And then we're still holding bills, and it's now March. We don't have them out. We're getting really close because of all the back entry needed for lab and pharmacy and just finishing up the outpatient ambulatory, having everything that's necessary to actually drop a bill. And then there's all the expense around the overtime associated with the downtime. Christy had relayed to me that they had to staff up. So while the organization's staffing up, we also decreased some of the volume of the care that we're providing in order just to keep up. And then remember, this is when COVID's ramping up. So that stress on our staff of doing the COVID and adding, COVID units, moving those units, they're now doing all of this on paper. And so there was a real reliance on staffing up and then really relying on those nurses that knew those downtime processes and were recreating them in the moment. Again, we had downtime policies and procedures. We had our binders. That worked for the first few days, great. But once you got into that additional downtime, not so much. And then, of course, there are all the hours worked related to the recovery of the systems and then all the back entry. And I'll talk about that a little bit more. So we had to bring all the other systems back on line as well. So we're just getting to that point now, and we're 5 months out. So definitely it's been a marathon and not a sprint. And this piece, the back entry of data, is so critical. So when you're down, just imagine the stacks of paper starting to on your med surg floor, your ICU, the manual processes of, we finally, a few days into this thing, we finally got those computers up so we could get labels on all those paper documents. But all that stack, that paper has to go back. The processes, the bins. So Staples, we bought all that. The teams went down to Staples and they bought all the labels. We bought paper, toner, all those things that we haven't used for years. We're now having to get those things, and we bought the stores out just to manage those process. So there's all of that paper, the orderly process, getting it back to where it needs to be so it can be put back into the medical record. And then that data for areas like lab needs to be discrete. The data, it can't just be a scanned picture in the EMR. Same thing on the pharmacy side for your allergies and those kind of things. And then we have this gap now when we try to do reporting for regulatory. We now have this gap in data where we have to get all this data back entered into our EMR. We also experienced some loss of data around some images. So one of the systems that was hit very hard by the Ryuk was our, I mentioned it earlier, our PACS system for imaging. We had about 40 terabytes of data, 1.5 million studies, and we're down to about 730 of those images that we have not been able to recover, and one image is too much, right? So we're doing a clinical assessment on the impact to patient care if we have to have that patient re-imaged, but there's real clinical impacts for that, especially around interventional radiology. And then people who didn't save data on their local PC to their drives that we have backed up at the hospital, if you had data stored on your C drive, that data was lost. So some of the big takeaways, just some practical examples here. When we went down, all of a sudden we realized we didn't have enough prescription pads. Think of that across all of our ambulatory space, ED, the OR, through the hospital. When we had to write prescriptions, we didn't have enough pads. So we had to quickly, fortunately, Michael Amos was able to help us get the prescription pads in, but just practical, having enough of those. We didn't have enough toner for all of our copy because of all the paper processes. And then again, the challenge of having on the paper documents, having mini staff, having never really worked in that environment, making sure we had the right information on there to take care of the patient, but also so we could drop a bill, so that we could actually capture revenue to keep the organization afloat. And then this was enterprise-wide. So it wasn't just clinical and dropping a bill, but it's our accounts receivable. It's all the vendors trying to invoice us. I can't tell you how many emails that I've received of, hey, John, we're going to shut your system down. You haven't paid. Well, no, we've been down because our accounting systems were down much longer. You're talking 50 days or so before those systems started coming online. So all of those workflows, that backlog, getting vendors paid, put all of that together. And then again, the backlog of paper for all of our clinical areas, and going back and making sure we have physician signatures so that the information is properly cataloged and stored. And then finally, to just close out with this, how do we prevent this? How do we prevent these kind of things from happening? Well, if you think about it in an analogy to your house, you put deadbolts on your doors, you might put bars on your windows, or whatever you do to secure your home. But if the bad guys want to get in, they can get in, right? So I can't say enough about having good backups. Fortunately, Sky Lakes Medical Center, we have not had to pay a ransom, and because we had very good backups. Every Windows-based system in our environment was encrypted, but our Linux-based systems and our backup system was a different operating system. We're able to restore good backups. We had a phenomenal tool called Cohesity. The number one recommendation from Talos and Kivu was to have a SOC, a security operations center that watches your network 24/7, 365. That's an investment worth making. And then just to point, education, you all, every person, every employee in your organization is the first line of defense. Understanding that when that email, when it comes in, says, open this attachment, or it's always with urgency, you got to do it now, or hey, you're going to get this bonus. Educating staff, our staff are our number one defense against this kind of cybercrime. We didn't have a written playbook. We're putting it together now, but we didn't have a written playbook. So we really struggled initially on what's the next step. So one of the things we started this week is some interviews. So we interviewed Ron, Christy. So we're starting to catalog that and make sure that we put a playbook. So should we ever have an extended downtime again, and I don't think it's a matter of if, but when, we don't have to think, oh, we need baskets for the ED. We need colored paper clips so we can put them on the chart in the ED. All those workflows that we did really well when we were on paper, we need to have those things in place. Again, having a long-term paper process. And then what you learn about the organization, we have incredible people. So I can say the clinicians, the stress that they were under and taking care of COVID patients. And on top of that, doing paper processes. I can't say enough about the good physicians and nurses at Sky Lakes, the incredible work that they did during that time, taking care of our patients and keeping them safe. So the final slide here is the recommendations. Here's what, from an IT perspective, was recommended. Number one was to have multi-factor authentication. So many of you use this with your banking. If you go, or you may use it already at Sky Lakes, we've deployed this more widely now, but if you want to get onto Epic in your home, you put your username and password and you get a phone call and it comes back to your device. That's multi-factor authentication. The next high was continuous monitoring, having a third party that watches your system, watches your logs 24/7, 365. I can't help but believe that if we had that in place, that time period from when the document was clicked at 12:08 till we discovered it at 1:30 a.m. the next day, to the time we had systems shut off about 8 a.m. The reason we only lost 730 records in medical imaging is because we physically stopped those processes. We shut it off. But that's, time is of the essence. Just as you know, emergency preparedness, time is of the, when a patient shows up in the ED, that is that golden time period of patient care. It's the same thing here, and having processes in place to mitigate that. And then they gave a couple of more recommendations around some things that we can do, but you can see in the bottom, security awareness program, incident response plans, and playbooks. All right, I think I went over my 30 minutes, but I wanted to kind of give you guys a holistic story. So I'm welcome to answer any questions that you have. I'll tell you what, since this group is really interested in disaster and planning, as you guys all know, communication is so key. If we wouldn't have had the Teams app that was available to us, so fortunately cell service worked, right? We had our Teams apps, and then the way operations management communicated with their team, think of all the staff that work for you. Do you have their phone numbers? So Christy goes, "Now I can tell, I have every staff member in my phone," and that's how we survived through this. We were texting. So anyways, happy to take some questions.
Thanks, John. That was really, really interesting with a lot of useful information. If anybody has any questions, go ahead and unmute yourself and ask them or drop them into the chat box.
Hi, John. I have a question for you.
Yes.
This is Stephen Vance from Lake Health District. I'm the IT director. Do you guys use any Barracuda email security system that kind of helps, filter out some of these emails that are coming in addition to using like Nobi for education on the end users? But I'm wondering if you guys used it before, if you're looking into using something like some kind of cybersecurity system for your Exchange or whatever email system that you use.
Yeah, we're a very heavy Cisco shop, so we're using Cisco's Ironport, and I can tell you that system is fine-tuned now compared to the way it was before. I tell our engineer Sam, who managed that system, "You save me about 30 minutes a day because I don't get as much spam email in my inbox as I used to get." So we use Ironport. We do use Nova4 for our education system, and we're young in that, but we're working on deploying that. So we do the phishing campaigns, and then I'm working with HR right now to get that set up so that we can notify managers if we have staff that repeatedly click right on those and use Nova4. So we're a strong, heavy Cisco shop, and we do not. I'll just be transparent with you all. Sky Lakes had an MDR, which is the 24/7, 365 monitoring. We had that in place. You all know what happened with COVID, how it impacted all of our bottom lines. So Sky Lakes went through a downsizing, and we did some cuts. We went through this. Not only did we have COVID ramped up, we had less staff because we had to let some positions go. So even in IT, we had fewer resources to manage this. 2 months before we got hit, as a cost savings measure, we removed the MDR solution from our portfolio to save that money. And as it turns out, again, perfect storm, 2 months later, we got hit. So I just think now in this world that we live in, there's really bad people out there. And ironically, guess what? Every one of them, we know where this came from. It came from the Stan nations outside of Russia. We know the name of the city where this came from. But ironically, those people are going to need healthcare someday too. It's kind of part of being human.
Great.
So
great. Thank you, John.
You bet.
Other questions for John?
So I'm going to answer a couple of these that I see in the chat space. We'll go real quickly. I'm happy to share the slides, and then also playbook. So we had our downtime procedures in place, like they were really good. So I was talking to Ron and Christy. Yeah, they worked for the first 24 hours, and then we had our downtimes forms. And then think of this from a clinical perspective. Think of all the nursing interventions that you do that you don't have a form for. So again, it was dealing with those things in the moment. Oh, we're doing this intervention, but we don't have a downtime form for that. So having systems that allow you, and I would, again, I don't think it's a matter of if, but when, and depending on your hospital size, the financial viability of the hospital, and then the resources to deal with this are a big deal. Yes, we're running Epic and Haiku Cantu. Great question. So when we were in the middle of this, nursing was focused on, trying to figure out all these processes. Oh, we don't have this form. Where do these go? Reinventing some of our downtime processes, but we brought Haiku and Cantu. And for those of you who don't know, those are the Epic applications you can get on your phone. A physician can place an order, get access to Haiku. Cantu's on an iPad. we finally came up with that idea probably 10, 11 days into the journey, because our EMR technically was still up. Asante Health System EMR was up, but we just weren't connected to them. So that worked really well, again, for a period of time. Physician could go into Haiku and they could see the past medical history. They could see, but guess what? As soon, if that patient had any care between that encounter in Haiku and the date that they were looking at it, it's already outdated, because none of that care in our system now in paper is being updated in Epic. So that worked for a little bit, and then it didn't become as efficient. But we deployed 42 iPads. We got a whole bunch of physicians on Haiku and Cantu, so that did help. So for the PAC system, what made it easier to start a new system than just original? So our original system here, multiple, was running on Windows 2003, legacy system, legacy IT equipment. It was completely down. Listen to this, the ransomware voided the warranty. The ransomware voided the warranty to get support with the system. Unbelievable. So we literally on a, I called somebody I trusted in the industry that had been working, doing diagnostic imaging, healthcare, IT diagnostic imaging for years. And I just said, tell me who the best people in the market are. And I gave those companies a call on a Friday. On Monday at 2 o'clock, we chose one, and we were live at noon that following Friday. And on that following Monday, we were doing full scheduling, full images at our outpatient locations and on site. And one of those other impacts I didn't mention is when all these systems go down, your radiologists now have to read imaging at the modality. So they have to go to the CT scanner, they have to go to the MRI scanner because they don't have PACS, right? So we could walk through nursing, ED, OR, patient cardiac, the CMU, the central monitoring unit, the stress on monitor techs, that if you don't catch that in the moment on that strip and catch it, and initially we couldn't even print, we had to get that all set up so we could, you miss it. So the weight and the stress, of having to go to the monitor's devices to document the information. So we improved in that downtime journey. We, like I gave examples of using a downtime computer with a Excel spreadsheet to actually print labels instead of handwriting labels. That was huge for staff. Being able to now document our medications on an electronic form on a computer was huge for staff. So it's all those innovation points.
Jerry Jo Payne, did you get your question answered?
Yeah, I'm really curious about, your point so well taken about practicing downtime. And, we have our Epic downtime about monthly. It's always on night shift. So night shift gets really good at it. In light of what you've experienced, John, at your organization, is there a willingness now to practice, not just EMR downtimes, obviously, but really the profound hit that happens with not being able to communicate effectively? When you look forward, has your organization talked about what that interval might look like and what those might be if they're on non-night shift?
Yeah, so I think everybody on this call who has an awareness would agree 100% with you that your night shift people are really good at this, because they get the once a month or once a quarter, whatever your downtime processes are, they know it well. So about a year ago, with Asante, we had this conversation, and it went from theoretical to practical. So we now, once a year, on Epic, we fail over. So we're running on system A and we move it on to system B. That failover brings downtime. So this last year, we actually did our first during the day downtime. And in that process, just so we could get some more exposure to those day shifts and those areas that aren't used to going down. And no, it hasn't been organization-wide. It was just with Epic. But in light of this, just to your point, here's the reality. We're just coming out of this COVID thing. We're just now getting resettled to bringing our systems back up. We're just now, I think we're just a couple of weeks from having all of our back entry done. So we haven't even really had a chance to come up with air and to even start those things. But part of that process was yesterday going and meeting with Ron and Christy to start that conversation. And you know what? We're going to have to resource some people in the organization to actually do something about this, right? So today, our downtime policies haven't changed. But I'll tell you what, we need to go capture. So our attempt was this week, we're at a point where we can start that process. But like Christy said, John, I have all those additional processes we've done. They're sitting in now in a box. I haven't had a chance to go through them and do something with them, but I've got them in there. So my commitment to them, because I'm so passionate about this, because I look at what's happening in the industry and I don't think the bad guys are going away. My commitment is to find a resource on my team that can work with each department in the hospital to go catalog those things. And what I envision is, just old school, having a 3-inch binder that sits there that, and that playbook being, here are the key things. So the example for the ED, it's going to be having a bin that's available so we can put the tubes when the blood's drawn to get that up to ED. Because guess what? We don't have the unit secretaries anymore. We don't have the people that would sneaker net all these processes. And just as an example, if you're in the ED and when it was on paper and you needed a previous medical record, you would call HIM and somebody would sneaker net that chart in. Guess what? Those resources don't even exist anymore. So our efficiencies have removed those FTEs from the organization. So I do want to say, even though IT is very expensive, we have gained at least a little bit of efficiency in areas. We discover it in processes like this. And now we don't have enough people to do all those manual processes. And that's why we make investments in technology.
Thank you so much.
Any other questions for John? All right.
Can I just say real quickly? So
Yeah.
I know Ron and the Region 7, I know Ron attends this and Sky Lakes has representation, but I'll just tell you, we are willing to share additional details. If you guys have questions and you want to talk through this, we're passionate about this because I couldn't find any information out there that I'm telling you, the IT work on this was unbelievable. The nursing work on this, because again, I would say most of your organizations can handle a 24-hour downtime or a 48-hour downtime. But when you go to days, it's a whole different thing. So between Stacy and Ron, if we want to do another Q&A or dive deeper, if you guys would like to set up a call with us, so we can have a conversation. If your IT departments want to speak to our engineers and our teams, because I've done that with the couple organizations, because we don't wish this on anyone. My heart sinks when I see another hospital get hit with ransomware. And I see the VP say, oh, we've just moved to downtime processes. Wait till next week if you're not off those downtime processes, the real impact to that. So we want to share whatever we can. We want to help the industry in any way that we can, prepare what to think about and to mobilize. Because I can't imagine earlier Lakeview Hospital. So I can't imagine being your size hospital and being hit with this. Sky Lakes, we're licensed at 176 beds, staff about at 100. Our census now is running in the 60s. We're not as big as Asante or OHSU or whatever, but for me, the thought of hitting a critical access hospital or a physician practice with this is insane. It's wrong. These people are thugs. It's about extortion. It's crime. It's terrible. So whatever we can do to help each other so that we don't become victims of this.
Thank you so much, John. I did record this, your presentation. Are you okay if I share it? I forgot to ask if you were okay if I recorded it.
Yeah, absolutely. Again, we want the word out there. Anything we can do. I know Stacy and Ron would share that. Anything we can do to help Oregon and help our colleagues be better prepared, or just even think about a few things. you know, when you're designing that new wing of the hospital, you might want to keep that whiteboard in the room, even though you may never use it. But I'll tell you what, when I talked to Christy and she talked about the communication that happened around that whiteboard, because, you know, we got Epic, we got these cool tools, we can replace so much of that, but having the wisdom to keep some of these things in place for, and again, around communication will result in better patient care, because doctors, nurses, clinicians find a way to take care of our patients, even if technology doesn't work, because we care about people. But how efficient we are at that and how long we can sustain that drag and drain, you know, having that whiteboard makes a huge difference.
Great, thanks, John. And I
You're
bet
welcome.
once we get back into conference hosting mode again at some point, I suspect you'll be seeing an invitation to come speak at a statewide preparedness conference.
Sounds good. Thank you.
Thank you so much for your time.
You bet. Thank you.
So we're going to pause and let people who are not part of Region 7 jump off the call. And I'd like Region 7 people to stay on.